This podcast is supported by an independent educational grant from Ipsen.
Welcome to our podcast, where we're going to talk about shared decision making in neuroendocrine tumours, or NETs, how to individualise patient treatment and factors associated with that. I'm Dr. Mohid. I'm a consultant gastroenterologist and lead of the Neuroendocrine Tumour Service of South Wales. And this is Sally.
Hello, I'm Sally Jenkins. I'm a NET patient of 15 years standing. It's made a great difference to my life, but it's now stable and I live a very good life.
So if we get on to the shared decision making about what examples in going back, you have the injections, somatostatin analog injections every month. And initially you had to come to the hospital and there was no choice. But then after services developed, there was the home care service, so that the injection can be delivered at home and a nurse come out to inject. And in some cases and some drugs and some countries where the injection or giving the injection could be taught, so the patient learns how to give it themselves or a carer or relative could learn. And I guess in the beginning where you're having to come to the hospital, parking is always is a major issue in the UK hospitals, but a disadvantage of just having it at home is that you'd miss the social aspect and seeing other patients. So it's important, I guess, if we have home care services, that patient support, nurse helpline ability for patients to have groups.
Yes, that's what happened to me. When I was coming into the hospital, there wasn't a nurse helpline and there wasn't a particularly extensive patient support group. But so coming into the hospital was important because I could talk over the previous month with the CNS, and I also bumped into other patients. But then as the service was set up and things matured, then home care was better because there was a nurse helpline and also there was a well-established patient support group. So I was getting what I needed in that direction elsewhere, not from the hospital. That's when, going home, being able to have it done at home became much more advantageous. And I think it is for a lot of people, actually, as long as you've got the other support, because it can be very isolating being as well. And one thing about the nurses who deliver the injections is that they are very good at doing that type of injection, but they are not NET specialists, and they don't really know what the injection does in detail. And so you can't actually discuss with them the sort of things that you can discuss with our NET CNSs or other patients.
And so it's important to have that ability to interact with the NET service, even if these injections are given at home or given around the country. If someone's travelling and people travel around the country or around Europe and come back. And so it gives that flexibility.
Again, this is very individual because some people want to go off travelling. Others, different age, maybe different stage in life, they want to stay home. And
we see that. So some people do want a routine and want to come to an institution or a practice in primary care with GP. So there's resource implications, but it is important to be, I think, giving choices to patients.
We're coming back to shared decision making here again. And again, that gives you a feeling of control as a patient. Because one thing that the cancer diagnosis does do, or any serious illness diagnosis does to a patient psychologically, is that it kicks the bucket of certainty out from under your feet entirely. And I don't know if anybody's ever really got it back afterwards. And NETs are very uncertain.
Yeah, I think it's that uncertainty that we have to communicate, similar to there's no right or wrong answer, right or wrong treatment. I think there's a need to be able to communicate that uncertainty. And
that's really important because I've heard, and a lot of patients have said to me, people say to me, you can't be seriously ill because you've still got your hair and you don't have chemo. So, you can't have serious cancer. Actually, you do. But it's just a different type of cancer. And so because it's such a long-term condition, where, as I said, you've got to reconstruct your own new normality, then you need that feeling of some control and need some feeling of choice, that you can steer your own ship. You can, have your own destiny.
I mean, you talked about the patient who had, going to the toilet and couldn't travel. And that reminds me of one of the very first patients I saw on moving. I remember her being in tears when I moved to South Wales because she had some bowel issues and just had to use public transport in a geographical area which she couldn't drive and had to get to her family, and was worried about getting onto the bus. And it was the uncertainty that I felt from her. But I guess the goals with the shared decision making is trying to figure out where you could get to, and having some certainty around that uncertainty, if that makes sense. That living.
I suppose it's a controlled uncertainty, if you know what I mean. There are some things that you can rely on, and the rest of it you just have to go with the flow. But the certainties, the things that you can rely on, are psychologically very good for you. For the patient, it means that you can actually think, I can cope with this, I can do it.
And I guess we have a cancer psychologist, so they run courses on managing uncertainty or living with uncertainty. Uncertainty is what they put on for patient groups and patients, which I guess it all boils down to having that shared decision-making process and then coming back to it. But I guess we were talking about injections, so bringing back to the injections. Obviously, some injections some people can be taught to self-inject, and some can't. There's one study. So there's a study, PrEF-NET, and that was looking at particular somatostatin and analog injections and comparing the experience in hospital, so having the injection in hospital, versus having it at home. And there were questionnaires to complete, but also some qualitative interviews, so just freestyle interview, and then some clever people who, not me, were analysing that data. And out of the study, there was quite stark results of 98, 99% of patients preferred to have their injection at home. And you can probably guess the sorts of things that they quoted and how it helped them. How do you think it would, having the choice of a home injection, what advantages does it have? We've talked about flexibility. Is there anything else that you think would be an advantage of having an injection at home? Have you had that experience?
I think one of the advantages, again, it's psychological, in that you become less medicalised, if I can use that word. If you have to go into a hospital or even to a GP surgery every month, that says patient, a person who is ill. If it's something that you can do at home, it's easier. You can carry on with your normal routine. It only takes half an hour out of your day, and it's not a problem. But it's also not pointing out that you are a cancer patient. Because again, that's the psychology of it. It's the way that people regard themselves. And if you regard yourself as an ill person all the time, and you're having all these reminders, and we have enough reminders in that, okay, my bowels are not normal. I have to go to the loo more frequently than other people do. So I get those daily reminders. I don't need the additional one that, oh yeah, next Wednesday, I've got to take the morning out to make sure I go to the hospital. That psychologically makes a lot of difference, as well as the practical.
I think out of that, you're right. I think out of that study, one of the findings through the interviews was that it did give patients confidence, and quality of life was improved if they could have it at home compared to hospital, and more psychological more comfort. With that study, the GEP-NETs study, one of the, as well as a lot of psychological impact in a positive way, they had more confidence in managing themselves. So it's the practical stuff, the cost of going to a hospital and and also the cost of taking time out. And if it's someone working, then I know sort of my own story and family story where you have to coordinate, and it's who's going to look after you, who's going to,
who's doing the pickup,
is work going to allow lots of appointments, and therefore, and if someone's self-employed, so self-employed people, they don't have that sick pays, they work for themselves, and that's something also which came out of that study, as well as the practical thing about getting to hospital.
It can get expensive.
It can, and obviously there are concessions in various hospitals, and most hospitals, especially if you've got cancer. But just having that anxiety if they're driving, worrying about getting on time and missing their injection and finding a parking space was something that also came out.
It's funny. A number of patients say, when I have those injections, they make me tired. And I don't actually believe that. I rather think it's the stress of having to get there or whatever makes you tired. Whereas it's not a physical side effect, it's a psychological side effect. And some people say, I get a dreadful ache in my leg. Well, you can, but not necessarily. And I think a lot of that is psychological rather than physical.
Yeah, anxiety does make you tired. And then when everyone knows, you tense up and you get stressed, and that's sort of the mental activity and concentration, and then you sort of have that adrenaline rush, and then it goes, and then you get that afterwards, sort of the adrenaline sort of seeps out, and then you have that down and you feel tired, and you're right, it could be that. I don't know for sure. The studies with the injections and neuroendocrine tumours such as GEP-NET, there's sort of systematic reviews of summaries of studies, David Seller, where they looked at a number of different papers, which also reported some of this preference for particular injections and preference for self-injection. Obviously, the injections, if you get into technicalities, some of them are pre-filled, so it's a syringe, so you can it's ready-made, and some have to be made up, and there's some solutions made up, and then relying on a nurse to do it in the right way, and they have to be reasonably experienced. So there's these other factors, but certainly some studies have looked at the simple injections where it's already made. There's more confidence generally in giving it.
Well, again, we're coming back to control and confidence all the time, aren't we?
Yeah.
And that's what good shared decision making does.
And I guess these are studies, and there's other studies similar studies, and there's sort of ongoing studies with patient-reported outcomes. And in the world where PCOR-NET, PCOR-NET, I think, and looking at patient-reported outcome measures, responses to treatments and all sorts of settings. And patient-reported outcomes are essentially what you talked about towards the beginning of our conversation, questionnaires, essentially. How do you feel on a scale of 1 to 5, 1 to 4, your bowels, various symptoms and quality of life. How do these things, they're coming on board in real life, in clinical practice, as well as how do you feel about them in just real life, filling them in, and does it give you any information for yourself as well as supplying sort of...
It does, actually. It makes you focus on how you are, which is good. It doesn't take very long. Now that we can do them online, it's quite easy. And it becomes part of the routine. And I think it's useful because I do tend to look back when I get a little reminder to fill in my "How are you?" questionnaire, and I will look back over the previous few months, and I think, oh yeah, I'm doing better than I was, or oh, I had a dip then. It's quite useful to know yourself. And when, sort of a slight sideline, when they were first introduced, I think right at the very beginning when you arrived, you were doing some data collection, and you used it in a study, and I think it got as far as a poster at one of the conferences. Well, we had a user support group, patient support group at that time. And when it came back that there was that poster, and that was us at one of those groups, I had the poster, I said, look, that's us. Somebody has taken notice of us, and we are, this is, this group. It really gave a boost to morale because we were all feeling a little bit ignored at the time. Because we did, as I said, we didn't have a dedicated service then. One has come now. But at that time, it was a really good psychological effect. So I think you get a group psychological effect as well as an individual one with that sort of thing. And then, of course, if people aren't interested in statistics, well, then they don't have to look at them.
No, I guess not. And on the individual level, those questionnaires, patient outcome measures, it does allow... It was helpful because it does allow the consultation to be tailored in a certain way. You can say, well, that's a thing there. It's important for the patient because they've gone off the scale. So let's explore that in detail.
Is there also like exception reporting? Don't some of the CNSs keep an eye on it? And if somebody is really dipping, they are well aware.
Yeah, I think
somebody's having a bad time.
Yeah, on paper, obviously, it's done in the waiting room, but digitally, we've got systems now which are coming into real life, which in the real world, which could help those shared decision making processes. And I guess it's going back to those shared decision making processes in the real world. I mean, how did these studies? Did these studies matter? Or do they inform what we think is important for patients?
Well, yes, of course they matter. I have been a numbers person, and quite often if somebody makes an assertion, I say, well, where's the research to back it up? Because that is important. I mean, that tells you whether it's opinion or whether it is fact as we see it, whether the numbers support it. I mean, there's always the interpretation, but if you haven't got the data, then you can't have interpretation. And I know that a lot of choices, particularly in the NHS, are made on research.
And on evidence. And then
on evidence. It's evidence-based. You've got to have it. Yeah, so I think some people understand the necessity for it.
Yeah, and I think that's important because some of these studies didn't exist 5, 6, 7 years ago, and clearly these have shown now that there are a number of factors in patient experience, that as well as patient outcomes, that are important in these decision-making processes when it comes to these treatments. Thanks, Sally. Interesting conversation. So as we come to the end of this podcast, I'd like to leave the audience with some concluding points. So what do you think the takeaways of our conversation have been?
From the patient's point of view, what patients want and need, I feel, is to feel that they are being listened to carefully and that their views are being taken into account. Because what that does is give back a feeling of control that something like a cancer diagnosis takes away.
And from the clinician perspective, those communication skills, empathy, ability to tailor the consultation and information, and tailoring the shared decision making to the situation and the patient, because people are different. When it comes to the injections and the choice in certain areas over injections, taking into consideration those other factors we talked about in terms of listening to the patient and how that would impact them in terms of the side effects or how it affects their life in terms of flexibility, travel, etc. So I think we've covered quite a lot today. So thank you very much, Sally. Hopefully we'll see you soon.
If you enjoyed this podcast and want to find out more, then please look for the Oncology Medical Conversation podcast under the account of Core2Ed Medical Education. Also, don't forget to rate this podcast, subscribe to our channel, and share it with your colleagues. Thank you for listening, and see you next time. This podcast is an initiative of Core2Ed and developed by NetConnect, a group of international experts working in the field of neuroendocrine tumours. The views expressed are the personal opinions of the experts, and they do not necessarily represent the views of the experts' organizations or the rest of the NetConnect group. For expert disclosures on any conflict of interest, please visit the Core2Ed website.